All right. Thank you so much for joining me. Today we'll be talking about air conduction and masked air conduction using plateau method. So in this Learn Masking series, please note that the expected order of testing is likely different than you expect. So this approach is valuable when working with clinicians with no previous masking experience and in working with computerized audiometry systems that employ automated masking. So the recommended hearing test order is first place the bone oscillator on the patient's identified better hearing ear and test bone conduction first. Second, place air conduction transducers on both ears and begin testing the patient's identified better hearing ear first. Then test the other ear, mask as necessary. Third, obtained masked bone conduction on each side as necessary. Fourth, complete any additional masked air conduction if necessary. And then 5, obtain speech testing. So we're all familiar with audiograms. This is our traditional audiogram with our x-axis that shows frequency going from left to right. We have low frequency going up to progressively higher and higher frequencies. And then on the y-axis, we have the top to bottom, soft to progressively louder. We have that bell curve within which we expect normal sensitivity to occur, centering around 0 dB HL. So the topic today is air conduction. We're presenting in dB, SPL, or HL. But basically, we're using sound pressure. At very, very soft levels, we can see that the sound pressure is isolated to just one ear. As we progressively make sound louder, what happens is that the sound pressure level begins to cross further through the head. If we have to exceed a certain amount, then what can happen is that the sound pressure level can actually reach all the way through the head, much like yelling through a pillow. So at this point, we don't necessarily know which ear is hearing the sound. Our instructions to a patient during a hearing test is very simple. It's a detection task. We're asking them to demonstrate by a hand raise that they're detecting that beeps are present. It's not necessarily what the frequency of the beep is, nor which side they're hearing it on. It's just simply, if you think you hear beeping, raise up a hand. So to know that we've isolated that left ear, we need to put some masking in the other ear. Otherwise, it's like yelling through a pillow, and I don't know if it's possible if the right ear is actually contributing. So by putting the masking over in that right side, it allows me to isolate the left ear. And this then lets me make a stronger statement about what the left ear is able to do. So when I put masking in on the right side and I isolate the left ear, I now discover that it's not as good as what I would otherwise believe if I had not done so. You can see the change in the symbol that's used, where we go from an X to a square. And this just denotes that we have placed masking in that right side, and we know that the response must be coming from the left side. All right. So after many years of trying to figure out how to make this obtainable in a visual format and really kind of try to take more of a perceptual or conceptual approach to it, I've kind of settled on this particular view of the audiogram. So this is definitely a non-traditional view. X-axis moving from the center of the head outward. We have our softest at the center, moving to progressively louder on the outermost areas of the audiogram. And then we have low frequencies at the top, going to progressively higher frequencies towards the bottom. And the idea is showing cause on one side, having an effect on the other. So as we all know, convention states that TDH have a crossover that's here at 40 dB. In reality, what we see is that it actually varies by frequency, and it looks like this. So crossover crossover levels can actually be even a little bit bigger than this on some patients. But in general, 40 is a safe level to use as a reference point. So remember that in order to really kind of make this easier to understand in terms of how one has an effect on the other, it's easiest to talk about this when we first know what our unmasked bone conduction thresholds are. So let's pretend we have a patient, and these are the unmasked bone conduction thresholds that we have found. We're going to assume that there's going to be some amount of crossover which can occur. If we exceed a certain amount away from this on one side, it can cross over to the other. So for the purpose here, we know that it changes or varies by individual frequency, but we're going to assume the traditional 40 dB. So let's pretend we have that patient. We obtain the air conduction in the identified better hearing ear. And we're going to pretend that this particular patient came in because they outright state that they're just not hearing well on that left side. Something's wrong. So we start the process of exploring on the left side, after we've already obtained thresholds on the right. And we present using an ascending method where we present at 20 and 30 and 40. Presenting here at 40, the patient does not raise their hand. We continue on and make things louder. To raise it again at 50, patient doesn't raise their hand. No surprise. What do we do next? We're going to raise it again. It's finally at 60, where for the first time, the patient actually raises their hand. It's at this moment when I look at that value and I say, is it possible that this could be crossing over? The answer is yes. It exceeds 40. The next step that I do, though, before I start isolating and adding in masking, is I'm first going to determine exactly at what point over, or at what point does the patient detect that something's happening. So I'm going to obtain an unmasked threshold first. So I find my unmasked threshold without any masking on the other side, because what it allows me to see is that patient's specific frequency-related crossover. And what I discover is that in this particular patient, it's actually not until 45 that they raise their hand. It could be that 45 really is coming from the left side, but it's over 40. So until proven otherwise, I'm going to assume that it is possible that it is reaching that right side. So to isolate that ear, make sure that the right ear isn't hearing this, I'm going to start the process of adding in masking. Just like always, I'm going to put my masking level in about 10 over my air conduction. The end result is that it raises the cochlea on that right side by 10. So if I present at 55, and it's at this point when it may just be crossing over to the other side, the masking has raised my cochlea 10 dB away from where it crosses over. So if I present at this level, is there any way that the right cochlea is hearing this? The answer is no. So I do this, and the patient raises their hand. I'm starting to think it may be from the left ear because I've raised the right cochlea away from where crossover is occurring. But if I want to be sure, what I can do is I can move it even further away by putting in an additional 10 dB, which moves the cochlea even further away from crossover by an additional 10. If I present at this level at 55, with that right cochlea shifted 20 dB now away from where it was, is it possible the right side's hearing it? The answer is no. It's at this point that I'm pretty certain that I have that left ear effectively isolated, and I know that the response is in fact coming from the left side. How about here? Once again, ascending, I present, patient does not raise their hand, make it louder, patient raises their hand. What's next? I'm going to proceed and find the unmasked threshold first. I find that it's here. I'm asking myself, is it possible? Is there any way that it could maybe coming from the right side until proven otherwise? Maybe. So I can put some masking over here, raise my threshold for the cochlea. If I present the beeps and the patient raises their hand, with this amount of masking in place, is it possible that the right side's hearing it? It's unlikely. If I want to be sure, I put more masking in, move that cochlea even further away. And if the patient raises their hand with that amount of masking in, then I know that it must be coming from the left ear. So let's go back to our traditional view. We now understand this idea of one side crossing over the other. So ascending method, present here, patient does not raise their hand, make it louder. They do not raise their hand, make it louder. Finally, hand raised. What's next? If you said find the unmasked threshold, correct. So that's what we do. Unmasked threshold comes in at 65. So it's at 65 when I ask the question saying, is it possibly coming from the other side? We are over the conventional of 40. So the answer is, until proven otherwise, yes. I'm going to proceed by putting masking into that right side. The end result is it shifts the right cochlea away from the point of crossover. If I present at 65 and that right threshold has been shifted away, so I present at 65 and the patient stops raising their hand. At that point, it may well have come from that right ear. So if they're not raising their hand at 65 and I'm looking for threshold on the left side, I have to make it louder. If I only raise the beeps on the left side without doing anything on the right, what happens is if I raise the beeps, we can see that the amount of crossover also increases. So I can't just move one without moving the other. If I'm going to raise my beeps by 10, I have to raise my masking by 10 as well, because I need to continue the process of forever shifting that right cochlea away from the point of crossover. So I do that, and I present here, and the patient now raises their hand. At this point, with this amount of masking, is it coming from the right side? Probably not. But they did raise their hand, so what am I going to do? It's the first time they've raised their hand. I need to find my masked threshold first with the current level of masking. No changes made, just find your masked threshold. So I do, and it comes in here. At this level with this amount of masking is probably not coming from that right side, but if I want to be sure, I can raise up the masking again and shift that right cochlea even further away. So at this point, if the patient's still raising their hand at 75, it must be coming from that left ear. So how about our 2000 hertz? We proceed just like normal. We start presenting and ascending 45, 55, 65, they raise their hand. At this point, do I need to worry about masking in the other ear? The answer in this case is actually yes. Why? Well, that's because we're not actually mixing newtons of force and SPL. We're now in TDH on each side. So we're presenting an SPL, and our reference is also, and our masking is SPL. So we need to move that reference point actually to where our unmasked air conduction is. So the point at which we have our 40 dB convention is actually anchored here, not here. So given this view, if I ask the question of, is it possible that the hand raise at 65 could be reaching the right side? The answer is yes. So what do? Well, I'm going to proceed just like normal, where I find my unmasked threshold first. And what we discover is it's actually down here. The patient missed it the first time. They're demonstrating that the threshold's here now. At this point, have I exceeded 40? Yes, I have. So until proven otherwise, it's possible that that could be the right cochlea that's actually responding. So I still need to use the process of shifting that right cochlea. And we have SPL, I'm masking an SPL. So I'm going to put 10 dB of masking into that right ear. The end result is it shifts the cochlea by 10. At this point, if I have this much masking in, the patient raises their hand, I can verify that I have enough masking in there by putting a little extra in there and shifting that right cochlea even further away. Patient still raising their hand. So I'm sold that that response must be coming from the left side. Continuing on, presenting beeps, ascending. Finally at 70, they raise their hand. What do? I'm going to first find my unmasked threshold. It's here. That clearly exceeds 40 for the convention for interoral attenuation or crossover. So I need to isolate my left side, put my masking in. It shifts my cochlea. Patient still raises their hand. I'm going to put even more masking in, make sure I've effectively shifted it far enough away. Patient still raising their hand. So I'm sold. How about the 8,000? 8,000 is a little bit tricky. We don't actually have a cochlea because we don't do bone conduction at 8,000 typically. So in this case, where do we reference our crossover point? Convention is usually that we use the unmasked air conduction as our reference point. Now remember, if we have any concerns, if we're thinking maybe the cochlea is actually better on that right side than where the unmasked is, we can always put some masking over there to really isolate out the left ear and make sure we know in fact that it's coming from the left side. But for convention, let's go ahead and anchor our crossover to the contralateral right side's unmasked air conduction threshold. Using ascending method, eventually I get my first hand raise at 70. And what do? I'm going to find my unmasked threshold. Without masking in, it comes in at 70. So this, until proven otherwise, is crossing over. I'm going to shift my threshold by putting some masking in. And at this point, the patient does not raise their hand. So until proven otherwise, I need to go louder. If I raise the beeps by 10, I need to raise the masking by 10 to keep shifting that right cochlea away from where the crossover may be occurring. So I do that, and patient does not raise their hand. Now what? Well, I'm going to raise both my beeps and my masking by 10. So finally, patient raises their hand. What do? It's at this point that I keep my masking the same, and I find out the softest level with this amount of masking in place at which the patient's still raising their hand. And it's here. To make sure I've effectively masked, I'm going to add a little bit more masking over here. So I know that that cochlea is shifted far enough away from the point at which the crossover first occurred. And it's at this point where I feel confident that the left ear is the one that's able to hear. So how about inserts? Well, inserts, we all know the convention is 60 dB of crossover. We also know that just like TDH, it's frequency specific. So at different frequencies, it may have a greater amount of attenuation. So the level of exact crossover may be much larger than 60. It's interesting to note that crossover at 2K actually occurs below where our convention is. So let's pretend we have our patient. Let's pretend we know what our unmasked bone conduction is. We've also obtained our air conduction over in the right ear. So what's next? we're doing our poor ear. We're going to use the ascending method. At some point, the patient does raise their hand. It is over the agreed upon convention of 60. What am I going to do? The first thing is the same. Find my unmasked air conduction threshold. I do that, it's here. That is clearly greater than 60. So I need to make sure that I know that it is in fact coming from the left side. I'm going to put 10 over my air conduction threshold. The end result of that is it shifts the cochlea on the right side by 10. If I present at 100 with this amount of masking in place and patient does not raise their hand, what do I do? So I need to raise both the beeps and the masking by 10 in order to keep shifting that right cochlea away from the point at which it may be hearing. So I do that. Patient raises their hand. Now what? It's the same as before. I'm going to leave my masking exactly where it is, but I'm going to reconfirm where my threshold is. And what I find is that it's actually here. So to make sure that I know that I have sufficient masking in there, I can raise it a little bit more. Patient's still raising their hand. I'm sold. Must be coming from the left side. Let's try something that's a lot harder. Let's move over to 250. So ascending, I raise the beeps, steps of 10, eventually 85, I get a hand raise. What's next? Same thing as always. Find your unmasked threshold first. I do that, it's here. This amount is over 60. So until proven otherwise, this is the amount of inaural attenuation, and it's possible that the other ear is hearing it. So now I have to present masking in that right side in order to further isolate the left. So I do that. I put 10 dB of masking in, shifts that cochlea. When I present the ear conduction with this amount of masking in, the patient does not raise their hand, so I make both the beeps and the masking louder. When I do that, it shifts the cochlea further away. Patient does not raise their hand. Now what? I'm going to make the beeps and the masking louder. Patient does not raise their hand. So one thing of notice is that my masking level is getting awfully loud here. Is it possible that the masking could be crossing over? The answer is we know what our inaural attenuation is for this particular frequency in this particular patient. And we can figure out that, yes, in fact, we may have a bit of that masking crossing over. Does this prevent us from proceeding? Not really, but we have to take it with a grain of salt and recognize the pros and cons. So I do not know the masked bone conduction threshold for the left ear yet. If the patient's raising their hand with this amount of masking, then I cannot be over masking. If they don't raise their hand, I should consider how good can the left cochlea be? How much conductive can it have? So is it possible for the left cochlea to actually have about, 105 or 100 dB of middle ear conductive? No. So the reality is even if I have this amount of masking in that right side, I'm not thinking the cochlea is down there. So I think I'm still safe. So I can raise up my beeps even higher, and I can raise my masking even higher. And I still know that it's unlikely that there is about 95 dB of middle ear conductive on that left side. With this amount of masking in place, the patient's not raising their hand. I'm still thinking that at this point, that cochlea or that left ear must be worse than what I'm able to reach with my audiometer. I'm at the limits. And so threshold has to be poorer than what I can see or what I can test. So I'm going to say no response at limits of the audiometer. So let's move on to a different patient, also difficult. So we're going to pretend we have inserts on ears where both of the ears have history of mastoidectomies. So we start on what the patient says is their identified better hearing ear. Then we proceed to the worse ear. So we find our unmasked thresholds like usual. At 1K, it's here at 100 dB, and we proceed with finding masked ear conduction threshold if possible. Very quickly, we start to run into a dilemma where I know that it's possible until proven otherwise that it could be crossing over and hitting that other cochlea. I don't have a lot of room to put masking in my other cochlea and really start shifting that right cochlea away without having to worry about it crossing over. So now what? So we do try putting some masking in. At some point, as we put the masking in, and we raise the beeps, the patient does actually raise their hand. So once we have a hand raise, I know I'm not over masking. And so I have to find threshold, keeping the masking exactly where it is. And I confirm, and it's here. Now what? So I raise my masking a bit more. Patient's still raising their hand. If they're still raising their hand, I am not over masking that left cochlea. So I feel comfortable that I've isolated the left cochlea. As we move to 500, I actually reach the level of 120 and the patient's still not raising their hand. If they're not raising their hand, it's not carrying over and reaching the right cochlea. So I can safely say that it's out at limits and I don't have to worry about crossover. Here, it's at this level that I find that the patient raises their hand without any masking in that right side. I can try putting some masking over there and shifting the cochlea away. Patient does not raise their hand. So it's possible that it was coming from the right. I try to raise up another 5 dB, increase the masking again. Patient does not raise their hand. Now what? So when the patient does not raise their hand, it is possible I am over masking. But I can also ask the question of what's the likelihood that the middle ear over here has that much middle ear conductive. It's unlikely that the patient has 75 dB of conductive on that left. And so I'm going to say out at limits. So how can I confirm which ear has the better cochlea? Because these are really tricky scenarios. I can't exactly use traditional masked bone because of the issue of crossover. And so it's a situation like this where you might actually use a different technique for obtaining masked bone conduction using something called the Rainville technique. And so that will be in another presentation. Thank you.